According to the National Council of Behavioral Health, 70% of adults in the United States have experienced at least one traumatic event in their life. Looking at that evidence, one would say trauma is not so rare. 10 or 20 years ago, I would have never imagined that systems across the nation would be engaging in trainings to help them become more trauma informed. What's even more mind blowing is that I have the privilege of being a part of this work. Hi, my name is Kristen Simpson, family nurse practitioner and director of healthcare activation with Alive and Well Communities, where our mission is to activate communities to heal. Today, we're going to start a discussion about trauma. And as we dive into this content, I want to remind everyone that's watching to be mindful of your own emotions as we kind of go over the layers of how trauma impacts each of us. Please, as we go through this presentation, take time and take space as you need it to pause, stop, and reflect or regroup as necessary. Let's dive into the content. Today, we will discuss the science of trauma. We invite you in this conversation to consider how this information causes you to shift your lens to using what we call the trauma lens. Think for a minute. Think of a family member or friend whose behavior you've tried to understand, but despite trying to understand, you still wonder what's wrong with them. They may not take good care of themselves. They may rely on substances to make it through the day. They may not be able to hold down a job, or they may get angry easily. This behavior may have come with some pretty harsh consequences, but they still seem to persist in this behavior. So we ask ourselves the question, what stories do we tell ourselves to explain behavior? What you learned today may help explain some of these behaviors. And after this slide deck, we hope you have the tools to begin to shift the question from what's wrong with them to what happened to them. Changing the question is imperative. And ultimately, by shifting the question, we believe we can identify new solutions that will make our communities healthier and more equitable. Throughout the training today, we want to return to this goal. How can we change the question we ask others? From what's wrong with you, or what's your problem, or why can't you seem to get it together, to what happened? We may also rephrase the question to something like, what's going on? Or how can I help you get through this moment or this day? The object is to remove blame from a situation and turn the focus on the experience of the person with whom we are dealing, and to discover the underlying cause of their behavior or their words so we can move into a space of understanding and or healing. We know that studies show that every person only needs one unwavering, buffering, supportive person in life to change the trajectory of their trauma. So, what is trauma? Trauma is the event, experience, and overall effects of an encounter. When we think about trauma, we must consider these three components. So, let's start with event. The event of trauma is an actual experience or threat of physical or psychological harm, or the lack, withholding, control of material or relational resources crucial to health and development. Experience, that is the second E, defining what trauma is. This is how someone assigns meaning to the event, which depends on the perception of the individual. We must recognize that the experiences of trauma is very unique in an individual piece of trauma. It is how we experience an event, and it is unique from person to person. It is not for us to say what is traumatizing to someone else. especially because we can't relate or we haven't experienced the same thing in the same way. And then you have the final E, effects, which are the results of a person's experience of the event. This can include neurological, physical, emotional, and cognitive effects, which can be immediate, long term, or lifelong effects as a result of trauma. Now we're going to talk about chronic trauma. Chronic trauma refers to multiple traumatic events happening to the same person. It could be the same type of event occurring over a period of time, like physical or sexual abuse, or it could be different types of events that occur to the same person over a period of time. For example, a child who was physically abused as an infant, had an intrusive, painful medical procedure at the age of 5, was in a car accident which killed a sibling at the age of 8, and was raped in the community at the age of 10. The impact of these events is cumulative and should not be viewed as separate, discrete events, but instead, each subsequent event brings forward memories and reactions from the previous events. Chronic trauma is also connected to toxic stress, or the kind of stress that negatively impacts the body because of continuous activation of our stress response system. Examples could include things like living in poverty, chronic hunger, or living in violent neighborhoods. Chronic trauma is typically when we see the most devastating impact on an individual's functioning in all areas, and what we typically will be referring to throughout this presentation. So let's dive in to discuss a few types of trauma events. Private event trauma. Private events include any type of abuse, like domestic or IPV, sexual, verbal, emotional, spiritual, financial, and technological. These events typically are conducted in secret, with the perpetrator possibly threatening to harm the victim or the survivor or others in some way if they say anything. Such threats can include harm to the victim, being removed from the home, or harm to a family member, manipulation, coercion, or force. In the case of young children, they may not be aware that what is happening to them isn't normal. In these situations, there is often a power imbalance between the victim or survivor and the perpetrator. This could be due to age, like child and adult. This could be due to financial dependence or role, like the role of a teacher or a priest or a police officer. This is important as well, as we learn that individuals with trauma histories often do not trust people in authority, as they have been harmed previously by such people. Each of us, in our professional capacities, may be viewed as an authority figure. This impacts our engagement efforts. So, remembering when a student comes to us and needs support in the healthcare area, they already may have distrust from prior experiences that we may not know the context to. And while we don't have to know the context to that, we should always extend compassion and grace and try to create a sense of safety when they come into our space for support. We also know that those who have experienced private events often talk about experiencing a raging sense of hopelessness, perhaps because of the secrecy and the power imbalance. They believe that there is no hope that anything will change for their situation. You may also see isolation, where people cut off from others because they just can't talk about it. They may also feel different from others or isolate themselves so no one will ever discover their truth. We also have sense of loss. It may be that they lost their innocence or they lost their safety. Each individual's sense of loss will and can be different. Can you think about a few private event traumas that weren't named here that you've witnessed? Now we'll move into public event trauma. Public event trauma are events that can be traumatic, that include natural disasters such as tornadoes or flooding, car accidents, painful and prolonged medical treatment, war, or crime victimization. These events typically are shared experience and talked about with others, and there's typically no judgment attached initially to be involved with the event. Individuals experience a public traumatic event often report a sense of hopelessness and helplessness. They may come from feeling that they have no ability to avoid or prevent the event. We can't stop a tornado, and we can't stop a flood. And like those experiencing private traumatic events, a sense of irretrievable loss is often reported. Think about one of the public events that we've all experienced this year was the COVID-19 pandemic. It was something that we could not foresee coming, and we couldn't really think about how it would impact our lives, and not just our personal lives, our professional lives. And when we think about public event trauma, COVID-19 is one of those events. But we'll talk a little later on how COVID-19 could be a part of a bigger trauma that someone is experiencing. Now we're going to move into discuss community trauma. Community trauma. This is characterized by a combination of experiences that negatively impact a community. And it's an event that impacts a few people but has structural and social consequences. As we shift our thinking, we have to begin to include community trauma, recognizing it has the same potential to impact others, just like interpersonal trauma. When we think about community traumas, we think about things that have happened within the communities in which we live in, within our school districts, within our healthcare spaces that are within our zip code or near our zip code. And what are some of those traumas in your community that you can think of that was a shared experience amongst those in which that you reside with? All right, now we're going to move on to historical trauma. Historical trauma. This is characterized by intergenerational, and it is not just about what happened in the past, but it's also about what is happening right now and still continuing to happen. These experiences can result in accumulative emotional and psychological wounds that are carried across generations. There are many, 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 many situations of historical trauma that impact us all. And to name a few, we can think about Holocaust experience. We can think about experiences of Native Americans, all the massacres and violent removals from their tribal lands that represent a severe communal loss. And when we think about the medical field, one that comes to mind to me is the Tuskegee medical experiment, where African American men were promised free health care to be a part of a study that wanted to study the progression of syphilis. The promise was when treatment became available, these individuals would be given treatment as soon as it was approved. The unfortunate side of this story is that treatment did become available, and it was withheld from the study participants at the choice and will of those conducting the study. Many of the men died, and even some of their family members suffered from long-term medical issues or even death as well. Babies were stillborn. Some wives passed away. Some wives had a lot of medical conditions because their husbands remained untreated with syphilis. It was recorded that about 100 of those individuals had lost their life because they were neglected to be given medical treatment. So when you think about the African American population and you think about healthcare and promises that healthcare makes, some people, because of this historical trauma, have issues trusting that space. So thinking about how it's difficult for some people to engage with healthcare spaces because of this distrust that is still happening to this day. Now we're going to move on and talk about racial trauma. Racial trauma is characterized by mental, emotional, physical injury caused by racial bias and ethnic discrimination, racism, and hate crimes. Race based experiences have detrimental psychological and physiological impacts on individuals and their wider communities. Cumulative effects of experiencing individual events of racism and living within a system that perpetuates racism. Some individuals experience prolonged incidents of racism, which can lead to symptoms like those experienced with PTSD or post traumatic stress disorder. It can look like depression, anger, reoccurring thoughts of the event, physical reactions like headache, chest pain, or insomnia. It can look like hypervigilance or low self esteem or mentally distancing themselves from the traumatic events. Some or all of these symptoms may be present in someone with racial trauma, and symptoms can look different across different cultural groups. Racial trauma can come directly from other people or can be experienced within a wider system. It could come as a result of a direct experience where racism is enacted on you vicariously, such as where you see videos of other people facing racism and or transmitted intergenerationally. It is important for us to think about how racism impacts those of different cultural groups when we encounter them in our spaces. And again, bringing back that word safety and making sure that we establish that and that we don't continue to perpetuate racism or unconscious bias within our spaces. Now we're going to move on to the next part of the training. We want to talk about the stress response system, knowing that when we are faced with stressful situations, our mind and body automatically respond in one of three ways, which is fight, flight, or freeze. The response is controlled by the most basic and primitive part of our brain, and it decides how to act to best support survival in that moment. For example, if you're encountered by a bear and you see the bear, your body is going to automatically choose one of the three things. It could be, do I run away from the bear? Do I stand up and try to fight the bear? Or do I freeze and play dead because I don't know what to do? This is a natural reaction that our body automatically does to protect itself. Now we're going to move on and talk about the prevalence of trauma. When we think about the prevalence of trauma and we think about PTSD, this was a diagnosis that was developed in response to the needs of veterans from the Vietnam War. Yet, adults who were in foster care have a higher rate of this diagnosis. We see that children who were placed in foster care have PTSD rates twice as high as U.S. war veterans. We also see that 47% of all children in the United States have experienced at least one adverse childhood experience, or ACE, such as abuse or neglect or the death of a parent, witnessing community violence in school or in the neighborhood. What does this tell us about some of our systems? We know that to go in a state custody, children theoretically have been exposed to abuse and or neglect already in their life. But like many systems designed to help, it may actually unintentionally do further harm to these individuals. And in this case, that harm may come from moving a child from place to place, disrupting relationships, and perpetuating not feeling safe and being disempowered. This difficulty in getting true rates is due to several factors, including the inherent nature of some of the types of traumatic events that children experience, the assets available to the field for detecting and counting these events, and confounding methodological issues between studies. So, when we think about the prevalence of trauma, we know that at least 1 in 7 children have experienced child abuse or neglect in the past year. And this is likely an underestimate. In 2019, 1,840 children died of abuse and neglect in the United States. In 2019, again, 1 in 5 high school students reported being bullied on school property in the last year. And each day, about 14 youth die from homicide, and more than 1,300 are treated in emergency departments for violent-related injuries. So this leads to the next discussion as we talk about adverse childhood experiences and or ACEs. This was one of the largest investigations of childhood abuse and neglect and household challenges in later life health and well-being. The original ACE study was conducted from 1995 to 1997 with over 17,000 participants. We ended up finding a direct link between childhood trauma and adult onset of chronic disease, incarceration, and employment challenges. Let's dive a little deeper. The Adverse Childhood Experience Study is a seminal research that identified the impact that childhood trauma can have on long-term functioning and outcomes. As you see here in this picture, in this graphic, it shows the span of different types of adverse childhood experiences like neglect, abuse, and household dysfunction. This was conducted in 1995 and shows 10 types of childhood adversities examined in the study: physical abuse, sexual abuse, verbal abuse, emotional neglect, physical neglect, and then growing up in a household where there are adults with alcohol and drug use problems. There are adults with mental health problems. There is domestic violence. There are adults who have spent time in prison, and there are parents who have separated. But we want to make note the ACE study only looked at 10 types of trauma. So we need to think about other traumas that impact children in today's experience. And let's talk about that a little more. So let's talk about how these adverse childhood experiences make an impact on an individual. So the impact of trauma. The Adverse Childhood Experience Study showed that traumatic experiences are vastly more common than recognized or acknowledged, that there is a powerful relationship between emotional experiences as children and physical and mental health as adults, including diabetes, heart disease, and some types of cancer, as well as depression, alcoholism, and drug abuse. The ACE study findings suggest that certain experiences are major risk factors for the leading causes of illness and death, as well as poor quality of life in the United States. Progress in preventing and recovering from the nation's worst health and social problems is likely to benefit from understanding that many of these problems arise as a consequence of adverse childhood experiences. The ACE pyramid that you see here on this slide represents the conceptual framework for the study and was designed to assess what was considered to be scientific gaps about the origins of risk factors. These gaps are depicted as two arrows linking adverse childhood experiences to risk factors that lead to the health and social consequences higher up the pyramid. Specifically, the study was designed to provide data that will help answer the question: if risk factors for disease, disability, and early mortality are not randomly distributed, what influences precede the adoption or development of them? By providing information to answer this question, we hope to provide scientific information that would be useful for developing new and more effective prevention programs. The ACE study takes a whole life perspective, as indicated on the orange arrow leading from conception to death. By working within this framework, the ACE study began to progressively uncover how adverse childhood experiences, or ACEs, are strongly related to development and prevalence of risk factors for disease and health and social well being throughout the lifespan. But there's more. The Philadelphia ACE study. Subsequent studies like this one have expanded the research to include a look at ACEs among inner city youth and the implications of intergenerational trauma. In the first study that was conducted in 1995, and the CDC, of the 17,000 participants, 69.9% of those participants had at least one ACE. In the expanded ACEs study conducted by the Philadelphia ACE Project, 83.2% of participants had at least one ACE. The graphic captures the original types of ACEs, which is childhood abuse, neglect, and household dysfunction, as well as expanded the ACEs, whereby the expanded ACEs consist of additional items that measure exposure to bullying, community violence, neighborhood safety, racism, and living in foster care. Health survey researchers surveyed 1,784 adult participants in Philadelphia about the original ACEs and 5 additional community level stressors. Using a more socioeconomically and racially diverse urban population, conventional and expanded ACEs were measured to help understand whether conventional ACEs alone can sufficiently measure adversity, particularly among various subgroups. The Philadelphia's demographic makeup looks significantly different than the original study, in which the majority of the participants were white, college educated, and middle income. In the Philadelphia project, where roughly a quarter of the residents lives in poverty, researchers found that almost 7 in 10 adults had experienced one ACE, and 2 in 5 had experienced 4 or more. The community level indicators, including witnessing violence, living in foster care, bullying, experiencing racism or discrimination, and feeling unsafe in your neighborhood. Researchers found that almost 40% of Philadelphians had experienced 4 or more ACEs of these expanded opportunities. Researchers found that almost 40% of Philadelphians had experienced 4 or more of these expanded community level ACEs. So let's kind of look at how ACEs impacts us. The Pair of ACEs tree. This illustrates the influence of a community environment on the lives of children and families. It depicts the relationship between adverse community events, the soil in which the lives of some children and families are rooted, and the adverse childhood experiences of their household environment or branches on which children and families grow. The leaves on this tree represent outcomes of stress and trauma, which are the adverse childhood experiences. ACEs are often recognized and observed in medical, educational, and social service settings, such as a well child visit or a child's behavior in class. Exposure to frequent and multiple types of adversity can increase a person's risk for maladaptive behaviors such as poor coping skills, hypervigilance, and early onset of chronic illnesses such as depression, heart disease, obesity, substance use disorder, ultimately leading to early death. In addition to health impacts, ACEs can have a devastating impact on social behavior, which may result in criminal justice involvement, lower educational attainment, and lower access to economic mobility. The Pair of Aces tree depicts a community planted in soil steeped in systemic inequities, dysfunction, and systemic racism, which robs it of the nutrients necessary to support a resilient, thriving community. Adverse community environments, such as neighborhoods of concentrated poverty, typically offer less access to economic mobility and or increased stress and fear associated with unfair policing practice, community violence, and systemic racism. The complex nature of inequities experienced in communities can contribute to and compound adversities that children and families experience within their homes. If we look at just these three examples in the soil and how that can impact the students and the way that they show up into our schools, into our healthcare spaces, poor housing quality and affordability, that's a necessity of life and a survival component. If you don't have good access and where you reside and good resources in your home, how can you be able to show up in the best way? Poverty is a portion of that. Not knowing the last time the student was able to eat a full meal. Is their stomach hurting because they're chronically hungry? Or is their stomach hurting because they have to eat something that doesn't agree with their body, but they don't have options? They don't have access to be able to get other items that could be better for their system. And then lack of opportunity, economic mobility, and social capital. Think about, for me, these three components here. Thinking about everything we discussed so far, the different events of trauma, the ACEs, and the soil, let's talk about layered trauma. So there is limited recognition of the various types of trauma that may impact an individual. Often only interpersonal trauma is recognized having an impact. And while interpersonal trauma is often viewed as more correlated and tangible, lying underneath all of the adverse community environments, which is the community trauma. Community trauma has roots in historical mechanisms like racism, historical oppression of certain ethnic groups and religious backgrounds, and transgenerational poverty. While there is a national narrative of historical trauma, each individual community has its own unique presence of historical trauma that layers on top of the national narrative. Historical trauma is the result of systemic oppression, and systemic oppression continues to fuel historical trauma to this day. And so we see from the individual trauma, there's a community trauma at large, there's historical trauma, and then systemic oppression. That includes things like the other traumas that are on the outside, like poverty, gender inequality, violence, lack of access, xenophobia, and continued racism. And so when we think about all of those things, the different types of traumatic events, the different layers of trauma, what is in our soil, as we think about the ACEs and how they impact at a very early age, we need to talk about how the brain develops in a traumatic state. So how does this happen? How do these childhood experiences result in these type of negative outcomes? Well, research now shows us how these childhood traumas impact our brain functioning. To understand, we first need to know a little bit about how the brain develops. At birth, the brain is about 25% the size of the adult brain in weight and volume, which is about less than a pound, but contains nearly the same number of brain cells or neurons, which is about 86 billion. The brainstem and lower brain are well developed, but the higher regions are less developed. And so the brain development is not about growing brain cells, but about growing connections between the brain cells, because the brain is wired to learn. Growing connections happens through stimulation or experience. Within the first 5 years, the most critical part of the brain develops. With repeated exposure, these connections get stronger and stronger. And in the field of neural development, it is said that neurons that fire together wire together. With each new experience, new connections are made between the involved brain cells and neurons. And with repeated exposure, those connections strengthen. As we move into adolescence, which is the second most critical period of brain development, the brain begins to prune neural connections that are weaker because they're not used frequently. This is a natural, healthy process, and the pruning process makes the existing neural connections stronger. But can these unused synapses return? The answer is yes, particularly those in higher portions of the brain. As we grow older, this may take more targeted, intensive, and longer interventions, but the brain has plasticity, which allows for this continued growth and recovery. It is never too late to have an impact. So let's discuss how trauma impacts the brain. So, as we noted, experiences and stimulation lead to increasing development of neural connections. It doesn't matter whether the stimulation is from positive or negative events, or the same process occurs. Repeated experiences have lead to stronger and faster connections, which results in more automatic responses. Think of how we practice skills when we want to improve, whether that's swinging a baseball bat or playing a musical instrument. We practice, practice, practice to get better, and it becomes almost second nature for us. We don't have to stop and think about what to do, it just happens. So, if a young child is exposed to a repeated trauma, that child's response to the traumatic event becomes wired into the brain, and with repeated exposure becomes a strong, immediate response. Think back to the survival brain and the three responses, right? Fight, flight, or freeze. When an individual is feeling unsafe or there's a trigger or reminder of a past trauma, this part of the brain takes over from the more rational part of the brain. Some of the impact this can have on a young child's brain affects the child's memory, attention span, perception, cognitive and language abilities, as well as ability to regulate emotions. So when we think about some of the students we may encounter into our space, and again, going back to that question we asked in the beginning, we're like, man, what's wrong with them? We really have to think about what happened to them. Was there a trigger that we are unaware of? Did we unintentionally re-traumatize someone in our space? And this is why they're behaving in the way that they are. And how do we immediately respond? By creating safety and build trust so that we can unpack, or hopefully just be able to get to a space where they trust us enough so that we can serve them effectively and efficiently. It's important to emphasize the role of cortisol. Cortisol does not only impact memories of negative traumatic events, but it can also create vivid memories of extremely positive moments in life as well. It's important to distinguish these types of memories from other types of memories being formed during times of stress during the stress response system. And when it's activated, it often invokes feelings throughout the entire body. So, when the stress response is activated, the release of cortisol can lead to a creation of what we call flashbulb memories of events associated with intense emotional reactions, both positive and negative. Sometimes you can think of a perfume or cologne of someone that you know and that you love. And when you smell it, it triggers that memory of them when you smelled it in that moment. And our brain makes those recall imprints during our lifespan. But let's talk about how these emotions affect us when we have an activating agent. So if you see that initial black line in the middle with the green and orange arrows, and that dashed line is our normal range of window of tolerance. On the outside, you have this activating agent. The activating agent is something that happens to us, whether that's a traumatic event, a repeated event, or a trigger. This activating agent then spews off a response from our autonomic nervous system, and it can push us to either hyperarousal or hypoarousal. Hyperarousal we call emotional dysregulation, and hypoarousal we call shutting down. So, with little time for recovery in between the events, sometimes you can get stuck. You can get stuck in hyperarousal or you can get stuck in hypoarousal. And so, let's talk about what it looks like being stuck in either. In hyperarousal, it can often look like anxiety, panic, rage, or hyperactivity. It could also look like you may scan the environment for risk of danger, mania, or hypervigilance. Hypoarousal can look like depression, dissociative episodes, fatigue, and or numbness. And it can impact your day-to-day functioning. And so now that we talked about trauma in the brain, let's talk about trauma and development. To understand the impact of trauma, we need to know the development stages the person was in when experiencing the trauma and their current stage of development and how that trauma history may impact them now. For example, a child who was sexually abused when they were a young child may receive appropriate treatment at that time. But as they move into puberty, new triggers may require additional treatment to manage the current developmental requirements. It's also important to emphasize the effects of trauma are not limited to only specific stages of development and may continue throughout the development until intervened upon. If a child experiences memory problems and difficulties paying attention, they may continue to experience that well into their adulthood. Trauma in early childhood. An accessible, attuned, and responsive caregiver continues to provide this early exposure to emotional regulation and learning how to interact with our environment. An infant cries, an accessible and attuned caregiver hears and understands the cry of the infant to know that there is an unmet need. I am hungry. I am cold. I have a wet diaper. I am tired. This caregiver then responds appropriately, meeting that infant's needs. The infant's brain learns this, which the brain becomes wired, to understand that I can trust my caregiver to meet my needs, and the whole world is generally a safe place. From this, the infant and growing child feel safe enough to explore the environment and learn to manage and master the environment, knowing that if it becomes unsafe, they can return to their responsive caregiver. If the infant's early experiences, however, are that their caregiver is not accessible, attuned, or responsive, then the world does not seem like such a safe place, and the child may be unwilling to explore the environment, and they do not have safe caregiver who can meet their needs. This too gets wired into the brain, and the child does not learn that there is a connection between their behavior and consequences or an effect on the environment, and relationships are not seen as responsive and safe. A responsive caregiver also teaches early self regulating skills by holding the infant close to their chest to hear the rhythmic soothing of the heartbeat and rocks the child, which also naturally helps regulate our body's response. We can use these tools later for an unregulated child by using rhythmic, repeated sensory experiences to help build this in the brain. The attachment between a child and caregiver is the primary source of safety and stability in a child's life. This earliest of relationships sets the framework for the child's development in many areas, including listed on here on this slide. As discussed before, an accessible, attuned, and responsive caregiver teaches the infant that the world is relatively safe and will meet our needs, that people can be trusted to support us, that we are capable of exploring and having an impact on the world. Our early lessons in soothing come from being held and rocked, as well as watching our caregivers manage their own emotions. Complex trauma exposure can interfere with the formation of a secure attachment bond between a child and her caregiver. Lack of secure attachment can result in a loss of core capacities for self regulation and interpersonal relatedness. Children exposed to complex trauma often experience lifelong problems that place them at risk for additional trauma exposure and other difficulties, including psychiatric and addictive disorders, chronic medical illness, and legal, vocational, and family problems. Toddlers or preschool age children with complex trauma histories are at risk for failing to develop brain capacities necessary for regulating emotions in response to stress. Trauma interferes with the integration of left and right hemisphere brain functioning, such that a child cannot access rational thought in the face of an overwhelming emotion. Abused and neglected children are then prone to react with extreme helplessness, confusion, withdrawal, or rage when they are stressed. A study by Davidson and Smith reported results finding that traumatic events experienced prior to age 12 are 3 times more likely to result in a post traumatic stress disorder than such events experienced after the age of 12. Young children are most vulnerable to the impact of trauma due to the rapidly growing brain. But young children have not had the time to develop the cognitive abilities or capacities that can help manage the impact. All young children tend to be more sensory driven, so the impact of trauma is seen much more in that area: lights, sounds, smells, etc. Again, because of their limited cognitive development, young children may not be able to understand cause and effect relationships. They may not understand that their mother could not prevent the tornado or losing all of their toys. How and where they place responsibility may not be based in reality. When a parent and child share exposure to a potentially traumatic event, the parent's capacity to manage their response impacts the child's response. If the parent becomes emotionally dysregulated, this will impact how the child processes and perceives the event. Because young children have little real control over their environments, they have less ability to manage or respond to potentially traumatic events. A 3-year-old has little ability to be able to avoid being abused by a caregiver or even to avoid exposure to witnessing domestic violence. So let's talk more about the impact of trauma in young children. We recognize that children are often going through trauma alongside their caregiver, and that the shared trauma impacts an ability to parent. And children may blame their parents and caregivers for not preventing the stress or trauma happening to them. So let's talk a little more about the impacts of trauma on young children. As noted previously, the first 5 years are the most critical period of brain development. The brain is very influenced by experiences, whether they're good or bad, at this age. So, the other major issue is that young children may not have fully developed language to capture their responses to the event. This may make it difficult to frame that trauma event or even to discuss this event then or later. We should not ever think that just because they don't have the language to talk about the impact, that it has not impacted them. Much of the impact for young children may be in not achieving developmental milestones, such as in language, or it may be possible that they regress in their development. For example, a child who is toilet trained may regress to wetting or soiling. This slide shows a list of other areas that may be impacted by young children. And let's take a look at that for a second. Delayed development of verbal skills, memory problems, regressive behaviors, aggression, excessive crying or screaming, problems with focus and learning, poor appetite, low weight, digestive problems. Irritability, sadness and anxiety, nightmares, sleep difficulties, compulsion to reenact or imitate traumatic event, exaggerated startled response, difficulty trusting others, lack of self-confidence, somatic complaints, and bedwetting. Young children often act out some components of the traumatic event in their play or interactions with others. This may reflect feelings about being unsafe or feelings about abusive interactions. In this, it's important to remember not to take away any actions towards you personally, but to know that this is just their way of expressing what is going on in their world. Young children into school age often report somatic complaints such as having stomach aches or headaches when there's no physical cause identified. So remembering those discussions when students come to you and they complain about something, but our rationale is not that there's a physical cause, that it could be something else and something deeper. Let's move on to discuss trauma in adolescence. So this slide lists the impact of trauma that adolescents may face. Obviously, any change in behavior or relationships can be a sign of some emotional concerns. We may also see stories or pictures that are violent or morbid in nature. This may cause concern in the adults, but it should again be examined through a lens of trauma and that they may be representing what is happening in their life and may not represent a plan to harm others. We need to remember that adolescence is the second most critical period of brain development, and that adolescent brain has some unique characteristics even within typical development. Such things as requiring a higher level of stimulation to feel normal, or interpreting anger or negative emotions to others' facial expressions than children or adults. Emotional numbing can lead to engaging in self injurious behaviors as a way to feel. And finally, discussing how trauma impacts adults. When working with children and adolescents, we need to think about their parents and their caregivers. The way an adolescent adapts to stressors has a lot to do with how well his or her family is functioning. It has been found that when adolescents lack parental support, they are more likely to have behavioral problems and experience emotional distress. A system of care study looked at the prevalence of trauma within caregivers of children who have experienced trauma. The prevalence rate was high, and the number of traumas experienced was on average 7 events, which means that this is now a chronic trauma. We got to think about this when we are attempting to engage with parent and caregivers around the needs of the child. The parent may not have much trust or authority and may be mistrustful of any support that's offered. Here, if you look at this slide, it'll show some of the symptoms that adults may display when they are also experiencing trauma and are displaying the results of that impact. As professionals in our roles with children and families, It is imperative that we change our perspective when a parent is not meeting objectives or goals from being non-compliant or resistant to being impacted by trauma, and help that parent manage through their own emotional and behavioral responses through that trauma lens. And so let's get back to discussing the trauma lens. Applying the lens of trauma to inequitable outcomes. And how do we apply the science of trauma and toxic stress to real life? What do we do with this information? It's important for us to see trauma if we're going to address it. We must see trauma that occurs within and through relationships, and those that occur through and in our social systems and structures. Now, we can begin to question how historical trauma, ACEs, and adverse community environments work on people's health, behavior, and life outcomes in ways that we don't outwardly discuss in the common narrative. So let's talk about now the core principles that helps us apply the trauma lens. In the Missouri model, there are 6 principles. There are 5 core principles that guide becoming trauma-informed, which are safety, trustworthiness, choice, collaboration, and empowerment. The core principles fit together like pieces of a puzzle. And only when all of the pieces are concurrently in place can an organization or a system be truly trauma-informed. The core principles help to achieve equity, and the individual pieces fail to fit together without equity. Equity is the glue that authentically hold the pieces together in a trauma-informed organization or system. Let's talk about what each core principle could look like. Collaboration. When we collaborate with those who come into our space, into our healthcare space as we service the community, collaboration shows that we honor transparency and self-determination and seek to minimize the impact of the inherent power differential while maximizing collaboration and sharing responsibility for making meaningful decisions as a collective. Empowerment. Empowerment encourages self-efficacy, identifying strengths, and building skills, which leads to individual pathways for healing while recognizing and responding to the impact of historical trauma and oppression. When we collaborate and we share that power with those who we serve, we then give them power and make them feel empowered about participating in that which matters to them, especially as it applies to their health. Safety. Safety means that we ensure physical and emotional safety, recognizing and responding to how racial, ethnic, religious, gender, and sexual identity may impact safety across the lifespan. So if one of the things that we like to do when we engage with people is then first make them feel safe within our space. And once we establish that safety, we can expect that our engagement with the participants or our clients or our patients or our students have a better chance of being a positive interaction. Trust. When we build trust, we are fostering genuine relationships and practices that build that trust, making tasks clear and maintaining appropriate boundaries, but creating norms for interaction that promote reconciliation and healing. It also shows that we understand and respond to ways in which explicit and implicit power can affect the development of trusting relationships. This includes acknowledging and mitigating internal biases and recognizing the historic power of majority population. But also, just as we talked about with the children, if we know that trust is near, then we begin to wire our brain to know that I am in a safe space when I'm with this person. And so how, as school nurses, Can we build trust with the students that show up to us to know that when I come see you, I am in a safe place and I trust you. And I trust you enough to collaborate and build relationship with you because you have then shared that power with me so that I can be a participant in this encounter. And then we have choice. When we maximize choice, we're addressing privilege, we're addressing power, we're addressing historic relationships that impact both perceptions about and the ability to act upon choice. Giving choice also shares that power with those in which we are in the presence of. When we allow them to make a choice about the engagement, they then feel like they have some control over the things that are happening to them, even if they can't control those traumatic events that are happening privately or publicly. Things like, would you like to sit down or stand up? Would you like to sit in the chair or would you like to sit on the stretcher? I need to look at both of your ears. Which ear would you like me to start with? Giving choice in those small areas can really help someone feel like you see them. And that is important in building trust and collaborating with those who we want to service. So now let's talk about becoming trauma-informed. In a trauma-informed approach, all people at all levels of the organization or system have a basic realization about trauma and understand how trauma can affect families, groups, organizations, and communities, as well as individuals. People's experience and behavior are understood in the context of coping strategies designed to survive adversity in overwhelming circumstances, whether these occurred in the past, whether they are currently manifesting, or whether they are related to the emotional distress that results in hearing about firsthand experiences of another. There is an understanding that trauma plays a role in mental and substance use disorder and should be systemically addressed in prevention, treatment, and recovery settings. Similarly, there is a realization that trauma is not confined to the behavioral health specialty service sector, but it is integral to other systems and is often a barrier to effective outcomes in those systems as well. People in the organization or system are also able to recognize the signs of trauma. These signs may be gender, age, or setting specific. It may be manifest by individuals seeking or providing services in these settings. Trauma screening and assessment assist in the recognition of trauma, as do workforce development, employee assistance, and supervision practices. The organization or system also knows to respond to trauma by applying the principles of trauma-informed approach to all areas of functioning. The organization or system integrates an understanding that the experience of traumatic events impacts all people involved, whether directly or indirectly. Staff in every part of the organization, from the person who greets the student at the door to the executives and governance board, have changed their language, behaviors, and policies to take into consideration the experiences of trauma among children and adult users of the services, among staff providing the services. A trauma-informed approach seeks to resist re-traumatization of clients as well as staff. Organizations often inadvertently create stressful and toxic environments that interfere with the recovery of clients and the well-being of staff and the fulfillment of organizational mission. Staff who work within a trauma-informed environment are taught to recognize how organizational practices may trigger painful memories and re-traumatize clients with trauma histories. So when we're thinking about becoming trauma-informed, we should ask ourselves, what is the problem we're trying to solve? What would healing look like in this place? What changes are needed so that healing can take place? And who needs to be at the table as we think about how we solve and heal these spaces? So what are the interventions? Transition from macro level to the individual level. Many effective therapeutic interventions are available for individuals of all ages through various individual or group modalities. We know that there's a growing evidence, however, that individuals with chronic trauma may not yet have developed the cognitive capacities to benefit from these predominantly cognitively based interventions. In those cases, we may need to start with more sensory interventions that focus initially on lower, more primitive parts of the brain to help build cognitive capacities. These sensory interventions are often repetitive, rhythmic activities that may mimic our early learning of emotional and behavioral regulation. Remember, brain growth is hierarchical. So we need to build a solid base to be able to support higher level development. You don't have to be a therapist to be therapeutic. One buffering supportive individual can mitigate the trajectory of trauma. The power of relationships in which we create safety and build trust. So then how do we continue to respond to trauma? We learn about trauma ideally to improve our response to children and adults who have lived experience with trauma, whether it's in mental health, domestic violence, education, juvenile justice, corrections, wellness, etc. Our first concern, obviously, is to do no harm. But unfortunately, sometimes what we do is unintentionally trigger a trauma response and increase an individual's level of feeling unsafe and causing more anxiety when we encounter them. Our interventions are also often ineffective. If we don't understand the psychological impact of trauma and how that can impact how someone shows up, then the use of behavior modification is common and may lead to escalating behavior rather than assist the individual in managing their psychological responses. It is imperative that we need to reconceptualize individuals' responses from being intentional to being psychologically based. Additionally, policies, practices, environments all need to be reviewed through a lens of trauma to ensure we are not triggering an individual that we have the capacity to support. Now moving on to back to changing the question. To become alive and well, we need to change the question from what's wrong with you to what happened to you. We're here to return to this goal, to figure out how we can remove blame from a situation, establish safety, and be that unwavering buffering support for those that we serve. And ask, what happened to you? And what's continuing to happen to you? And how can I help you get through this moment or through this day? Thank you for joining our discussion on trauma in healthcare. We hope that you enjoy. Thank you for joining our discussion on trauma in healthcare. We hope that you enjoyed this learning experience, but most importantly, we hope that you feel inspired to activate change within your own healthcare community. If you have any questions, please do not hesitate to email us at info@awcommunities.org. Thank you so much again, and be well.